Good afternoon. Welcome to Envision New Mexico. This is Kirsten Bennett. I'm going to be your facilitator today for PEDX, which is sponsored by New Mexico chapter of the Academy of Pediatrics. And we have with us a guest speaker who's going to talk to us today about renal topic, renal stuff. So I'm just going to run through some of our housekeeping slides at this point. And for those of you who are signing on, we'll give you an opportunity to either tell us where you're practicing from in the chat box or unmute yourself. So we are recording our session today, and we are broadcasting live. So if you have questions that you want to address to Dr. Staples about patients, just make sure not to include any protected health information. We would absolutely love to see your face. So if you notice on the screen, you are able to turn on your camera and mute and unmute your audio. So you can use the audio on the phone, or you can use the audio on the computer. Either one works well. But actually, we'd love to see you. It does change the way we have a conversation. If you want to receive CMEs or CUs for the session, you must tell us that you're here, and you can do that either via the chat box or unmuting yourself. If we call on you to ask a question, you can say pass. You don't have to answer, but sometimes, since we're such a small community of pediatric providers, we tend to know each other and want to share our experiences. But if you feel like you don't want to do that today, that's fine. Oops. You can go again here. Oh, not kidding. No, there we go. Okay. So again, joining the conversation, you have a video button and you have an audio button. And then to join via telephone, those instructions were on the first slide. Here's our disclosure and accreditation statement, which we're required to do. This is Category 1 AMA credits for physicians, and we also offer the same Category 1 credits to the counseling and nursing boards. And for dietitians, you just use your CME credits. Blue Cross and Blue Shield of New Mexico have partnered with us in offering reimbursement for case consultation. So if you do choose to use that case consultation as an option, please let us know. We can help talk you through that process. So now's a really great time to tell us if you're here. I noticed that there were a few chats. So we've got Dr. Ciudad and Dr. Helm on. This is a great time to hear your voice if you'd like to actually talk to us today. You do have to unmute your microphone. It's the only requirement there.
Nurse Helen is on there.
Okay. All right, great. Elaine Silos. Okay. And Dr. Ciudad, I guess we're still trying to work on sound. It looks like we're not muted. So I'll let Michelle work on that as we continue to go through the slides here. All right, so I'm going to turn it over to Dr. Staples. She's going to talk about hydronephrosis in the neonate. And is there a way that you want people to respond to you? Do you want them just to ask questions when they have questions, or do you want to wait till the end? It's up to you.
I'm fine if people want to ask questions as they come up.
Okay.
Absolutely.
All right, so I'm going to turn the clicker over to you.
And I might steal the mouse.
Oh, you like that better?
Well,
yes, got the pointer.
If need
Perfect,
be.
yes.
Great. Well, I'm Amy Staples. I'm one of the pediatric nephrologists at UNM, and I appreciate being asked to come talk today about hydronephrosis in the neonate. The goal will just sort of be to refresh, I think, people's memories of medical school and residency, and then to be available to answer any questions. And at the very end, I actually have included our sort of rough protocol for how we suggest people handle hydronephrosis in the nursery, and you can certainly use that in your practice. It's a little bit different than what we'll go through in the talk, but I'll sort of address that at the end. So let's see. Over here, there we go. So briefly, objectives. We'll very briefly review kidney development and embryology, not to torture anybody, but mostly because I think remembering that can be actually very helpful when you're thinking about hydronephrosis. And then talk a little bit about the etiologies of hydronephrosis, and then the risk factors and evaluation and management. And then hopefully at the end, you'll have an idea on when referral is appropriate and when things can be managed locally. So there's going to be 4 cases that I'll just briefly mention at the beginning, and then we'll return to them at the end and hopefully have a better sense of how we would deal with these kiddos. The first is a 38-week AGA male who had known severe unilateral prenatal hydronephrosis, otherwise a routine prenatal history and normal amniotic fluid levels. So throughout the talk, I'd like you all to think a little bit about possible etiologies and then how you might manage that kiddo. Second, former 28-week premature infant who's now 4 weeks old, feeding and growing in a NICU or a level 2 nursery somewhere, diagnosed with a febrile urinary tract infection. Next is a 10-day-old in your office for a routine newborn check, and family brings in a prenatal finding of cystic kidney. And then the last are parents in your office for a prenatal visit. I don't know if that actually happens anymore, but if it does, they're 30 weeks, mom is 30 weeks gestation. There's known severe oligohydramnios that was diagnosed at 18 weeks. Fetus is a male with known severe bladder distension and actually had a bladder stent placed at about 22 weeks in Phoenix. We don't place stents in New Mexico, but she decided to go to Phoenix and have that done. So quickly breezing through embryology, just as a little refresher. And this, I think, is going to be the most important thing to kind of keep in your mind, gross anatomy of the kidney. Obviously, here's the outline of the kidney. This sort of area is going to be the majority of your parenchyma. So glomeruli residing here in the cortex, and then down in the medulla with collecting tubules, and the loop of Henle. And then really this is going to be our focus here. So the hilum, it contains the pelvis, what we call the pelvis, and then the artery and vein. And really our focus is going to be sort of here on the collecting system and the ureter. So a little bit briefly on development, we'll try to spare the gory details, but way back, remembering from medical school, there's 3 actual kidneys that develop embryonically. So 3 sort of sets of excretory organs. The first 2, the pronephros and the mesonephros, are just primitive and they resolve over time. And then we'll spend a little bit of time talking about the metanephros, which is the permanent set of kidneys. Begin to develop at about the 5th week of life and start to function about the 9th week of gestation. And the important thing I think to think about in this are that there are 2 sources for the permanent kidneys. There's the light pink and then the dark pink. And the names don't matter so much. They're a little difficult, a mouthful for both. But really the idea is that the light pink is the ureteric bud, and that's responsible for developing the ureter, the pelvis, and the calyces, as well as the collecting tubules, as you can see here. And then the darker pink is really what develops into the nephrons. And these 2 things have to sort of come together embryologically in order to stimulate each other to develop properly. And that is likely thought to be the source of several of the things that may go wrong when things are developing. A little bit of a review of nephrogenesis. Glomerular development begins at about 8 weeks. There's a gradual increase between 10 and 18 weeks, and then a rapid increase up to 32 weeks. And then an important thing, I think, especially if you spend a lot of time in a nursery, a level 2 nursery, or with newborns, is that the nephrogenesis is complete at about 32 weeks. So no further increase in nephron number after about 32 weeks. Also important to remember, if you're ever taking care of kiddos who are a gestational age of under 32 weeks, they may not have a full nephron development yet. So also important to remember. And the newborn kidneys, each kidney contains about 800,000 to 1 million nephrons. And again, I think just to sort of bring that point home is that nephron formation is completed by birth, or even perhaps a little bit before then. So you're not going to get any more nephrons throughout your life. Function does improve, and that has to do with blood flow and an improvement in tubule function. And that function improves until about 2 years old, when we typically will see adult levels of kidney function. that was our brief whirlwind tour of embryology, and we'll move on now into hydronephrosis. We'll spend a little bit of time talking about epidemiology, and then a nice breakdown of terminology and some new consensus papers that are out about how to deal with it. We'll spend some of our time talking about that. So prenatal hydronephrosis is identified in about 1 to 5% of all pregnancies, and the frequency of that varies depending on diagnoses, as well as definitions and how frequently people are examined. But here's just a picture of a prenatal ultrasound, and you can see hydronephrosis there in both of the kidneys and the baby. About 35% of those who are identified prenatally will go on to have some postnatally detected pathology. So that's a pretty small number. And that's one of the things I like to reassure families, is that we see hydronephrosis a lot in kids, and rarely, or at least 36% of the time, it has some significant pathology, which means that, you know, the other 70% don't. So that can be reassuring to families. The majority is detected around 20 weeks, although you can see it as early as 12 to 14 weeks, depending on the severity. And of those detected in the second trimester, 33% resolve by the third trimester. So if any of you are family medicine docs who are doing prenatal care as well, that's an important thing to reassure moms that we'll just continue to look, but some of that will resolve prior to delivery. So when to worry? I think that's a common question that we get, and unfortunately there's not a consensus on prenatal imaging correlating with postnatal abnormalities. There have been quite a few people who've looked at that, and there's some consensus perhaps that you're more likely to see postnatal anomalies when you have anterior posterior pelvic diameter as listed here. So you can see AP diameter we'll talk a lot about. It's just a little bit easier, but that's just the measurement that's typically done, anterior to posterior pelvis diameter. So you can see if it's greater than, 6 millimeters at 20 weeks, 8 millimeters at about 20 to 30 weeks, or 10 millimeters at 30 weeks, you're a bit more likely to see postnatal pathology. So you can sort of counsel families appropriately based on that. So a little bit about terms. I think that terms can be a bit challenging because different radiologists will use different terms, and you don't always feel confident that you know what you're reading about, especially if you don't have images. Hydronephrosis is just the generic term about dilatation of the collecting system to any degree. So that's this area. That could be just the pelvis, or that could be further up into the calyces. Pylectasis or pelviectasis is dilatation, again, of just the pelvis. So that's a little bit more specific to just the pelvis area. And then calectasis or pelvocaliectasis includes dilatation of the calyces. So that would be a little bit further up and perhaps considered to be a little bit more severe. If you're getting imaging at UNM, our pediatric radiologists will use mild, moderate, severe, and we become fairly accustomed to that. I do realize it's a bit subjective, but we, again, it sort of helps you delineate how significant you think the hydronephrosis is. There is a radiologic grading system, again, that we don't use, but I certainly have seen some babies come in from outside institutions where radiologists did use the numerical grading system. So I just wanted it to be available for you to review in case you do get some reports that talk about a grading of hydronephrosis. And you can see it makes sort of sense. It's just a continuum. Grade 1 would be what I would say we would consider relatively mild. Grade 2 is a little bit more dilatation of the pelvis with some 5 to 10 millimeters dilatation there. That we would probably consider mild to moderate in sort of our grading system. And then we're sort of moving on into the moderate to severe with grade 3, 4, and 5. And you can see that there's just progressive dilatation of the peripheral calyces there, with grade 5 sort of just being completely blown out kidneys. So I mentioned a little bit about some new nomenclature, and I don't think that this has taken off quite yet, but I do anticipate that it will sort of become the way that things are described, because it actually is a very nice classification, and it really helps you understand both prenatally and postnatally what you're dealing with, and it's a great communication tool. It's from the multidisciplinary consensus on classification of prenatal and postnatal urinary tract dilatation that was published in the Journal of Pediatric Urology a couple of years ago. And it really is trying to get providers to utilize that term urinary tract dilatation instead of hydronephrosis. And I think it's going to take a long time, perhaps never, to get people to make that switch. But I think looking through it, and if you have any interest, again, the references here, it's a great paper to read, and it really can give you some good baseline information about what you're looking at. So it breaks it down into both prenatal and postnatal risk stratification. So we're looking here at the prenatal slide, and you can see that it differentiates the degree of hydronephrosis as well as the age of the fetus. So here we have 16 to 27 weeks, 4 to 7 millimeters, and then greater than 28 weeks and 7 to 10 millimeters. And then these infants here on the green side have only hydronephrosis, or only sort of pelvis and calyceal dilatation. And those are going to be kids with nothing else identified who are going to be at pretty low risk for postnatal pathology. And then our increased risk group of kids are going to be more significant hydronephrosis, so greater than 7 millimeters when they're younger, greater than 10 millimeters when they're over 28 weeks gestation. And additional abnormalities you can see here. Not only do they have central calyceal dilatation, they have peripheral dilatation, there may be parenchymal abnormalities. We look a lot at the thickness of the parenchyma to see if there's been any damage to the parenchyma. Is it echogenic? Are there abnormalities noted there? What do the ureters look like? What does the bladder look like? And then oligohydramnios. Those things are going to up your risk for having postnatal disease, and that can be a great way to sort of help stratify families if you're talking to them prenatally. And then similar looking slide for postnatal risk stratification. Looking at, again, we sort of have the green, yellow, and red, I think, to give you an idea of easy course, perhaps a little bit more difficult. And you can see these all say greater than 48 hours. There's a lot of discussion about when to ultrasound postnatally, and I think we're certainly guilty of ultrasounding early at UNM because babies go at 24 weeks, at 24 hours, and sometimes we feel it more important to actually get that ultrasound before they go. So we frequently will encourage our newborn nursery to ultrasound babies before they go. If you happen to have, a C-section or someone who you know is going to be in for 48 hours, certainly it's okay to wait that 48 hours. But frequently we understand that the logistics of it are that it's an earlier ultrasound. So what about 48 hours? If your AP diameter is 10 to 15 millimeters, and it's just central calyceal dilatation or just pelvic dilatation, no other abnormalities, that baby's going to be relatively low risk. And then you move into sort of this moderate risk group where you're greater than or equal to 15 millimeters, and you have some peripheral calyceal dilatation, so a little more significant looking hydronephrosis, maybe even some abnormal ureters. That baby is going to be at sort of an intermediate risk and may require a bit different follow-up. Then you've got your kiddos over here who are going to be high risk and probably do warrant more aggressive intervention and evaluation, perhaps even before they go. Those are kids who have greater than 15 millimeters of hydronephrosis or of calyceal dilatation with additional abnormalities. Parenchymal abnormalities, bladder abnormalities, or things like that. Those babies are going to need further evaluation before they're discharged. And then you can look at, based on what your risk determination was, these are the recommendations that come from that consensus group. And again, at the very end, we'll talk about our recommendations. They're a bit different, but I think these are a very good guideline. These are we're a bit more conservative than this, and that may just be our experience in practice. But again, I think a very good guideline for thinking about how to manage these kids outside the nursery. So kiddos who are low risk, the recommendation really is just to repeat an ultrasound. They say 2 to 3 months. Our protocol is usually 4 to 6 weeks. But again, just a repeat ultrasound and monitoring from there. PCUGs are not recommended unless there's some other concern that you have in that baby. And a renogram would not be recommended as well. And then antibiotics, obviously, if we're not super concerned about reflux, we're not going to recommend prophylaxing those babies. So this intermediate group here, VCUG is typically recommended, and I think we would probably follow that practice as well. Whether or not you do that before the baby is discharged, I think depends a lot on your relationship with the family, where they live, how comfortable you are with whether or not they will return to do the VCUG in a few days. And certainly we use all of those things in our decision making as well to recommend VCUGs prior to discharge or not. And then antibiotic prophylaxis, this is certainly what our group is doing. And we're prophylaxing kids who have greater than grade 3 or grade 3 or greater reflux on a VCUG, or pending a VCUG, and that's a little bit personal preference. But once you have the VCUG, if you have greater than grade 3 reflux, we are prophylaxing those kids. For kids with grade 1 or 2 reflux who have not had a febrile urinary tract infection, we are not prophylaxing those, really just encouraging families to be very vigilant in looking for urinary tract infections. And some of that is based on some data out of the RIVER study, which was a very good study. It didn't give us exactly the information that we wanted from it, unfortunately, but it was a very well done study, and it does have some good information about increased risk of urinary tract infection if with grade 3, 4, or 5 reflux. And then if the VCUG is negative in this group and your hydronephrosis persists greater than 3 months of age and is not improving, then there's a recommendation to consider proceeding with a renogram. And I think if you found yourself in this boat, that would probably be a reasonable time to refer and get the opinion of the urologist at UNM whether or not they would recommend proceeding with a renogram. And then our high-risk group, certainly VCUG before discharge is going to be absolutely recommended. Similar antibiotic prophylaxis as the intermediate risk kids. And then similarly, if the VCUG is negative, proceed with a renogram somewhere around 2 to 3 months of age. And again, some of that is a bit dependent on family, dependent on how significant the hydronephrosis is. Also, when we do our renograms, our nuclear medicine group is willing to do them unsedated in kids under 3 months. So lots of times we use that as our cutoff because otherwise they have to have sedation and do that with the pediatric sedation team, which can be a bit more involved and a bit scarier for families. So if we think we're going to need a renogram, lots of times we try to get it under 3 months and inside that window of being allowed to do it without sedation. So moving on just to a few pictures that just to give you all a little bit of visual of what we're talking about. So I'll start here in B because I think it's a nice outline sagittal view of the kidney here. This is all very nice healthy parenchyma, and you can see here just central calyceal dilatation. So I would call that pelvic dilatation, nothing that's really significantly up into the peripheral calyces there. You can see here this is a little bit more of a sliced through view of the kidney, but again measuring about 11 millimeters, but really just the pelvis there. Similarly here's the outline of the kidney. There's your 8 millimeters of pelvic dilatation. This, I think, starts to show you a little bit more of the calyces here. Here's the outline of the kidney. A little perhaps more calyceal dilatation, but very healthy normal parenchyma. All of this out here is very normal looking. So that would be very reassuring to us when we saw that. And then this is a bit more significant, and you can see here we've got not only some central dilatation, but we're out here into the peripheral calyces here. You can see that down here as well. Still with some fairly reasonable parenchyma, but that might be a kid that we're a little more concerned. If we don't do something about this degree of hydronephrosis, we may actually get some damage to this otherwise pretty healthy appearing parenchyma here. And then you can see a bit more significant measurement here with the parenchyma sort of sitting out here. And then these are the kids that we get a bit more concerned about. So here's a 21 millimeter, and you can see that this parenchyma here is not nearly as robust looking as it was on the previous images, similar to this here. So these are some kids who have some parenchymal thinning. Perhaps this kiddo has a little cyst here. And then this I just threw in because we will talk a little bit about bladder wall thickening in the end. And this is just sort of demonstrating that here. Most ultrasound images will measure the bladder wall for you, so that can give you an idea as well. 2 millimeters, 3 millimeters, sometimes even 4 millimeters is pretty reasonable, but more than that, then we get concerned that there may be some bladder wall thickening there. So moving sort of past describing what we're looking at into sort of thinking a little bit about etiologies and what's causing the hydronephrosis. And typically, you know, when I go through it with families, especially when I do prenatal visits with families, I really talk about kind of the big three: reflux, obstruction, and duplications. And I always mention to families as well, and I would actually put that even probably before duplications, is just idiopathic. We find a lot of hydronephrosis that we don't find etiologies for, and rarely do those cause any long-term renal sequelae. So I think that's important for families to know, that we might embark down this path and actually not ever figure out what it is. So we'll spend a little bit of time talking about some of these. I do have multicystic dysplastic kidney on here, not because it's hydronephrosis, because it's not, but frequently it's mistaken for hydronephrosis, especially in prenatal ultrasound. So we may get a family who came to us thinking that they had a multicystic dysplastic, and we did some postnatal imaging and found out that it was actually severe hydronephrosis, or vice versa. So those are instances that need to be dealt with as well. So starting with reflux. Reflux, I think, a review for everyone, is retrograde flow from the bladder into the ureter, and there can be primary reflux and there can be secondary reflux. Primary is reflux that's associated with an otherwise normal lower urinary tract, so no other pathology identified to cause the reflux. And then secondary is due to an obstructed or poorly functioning lower tract that then, because of that obstruction or poor functioning, results in secondary reflux. A little bit about epidemiology of reflux. It's about 1 to 2% of the population, although that's likely an underestimate because lots of reflux is probably never identified. But keeping that in mind, it's obviously not terribly uncommon. About 17 to 37% were prenatally diagnosed with a finding of hydronephrosis. So that leaves a big proportion of kids who didn't have any hydronephrosis prenatally and present with some other indication to look for reflux, and it's found that way. Interestingly, 25 to about 30% of siblings with reflux kids with reflux will have a sibling with reflux. And that's, I think, an important thing that I talk to families about if they are expecting another baby and they have a kiddo diagnosed with reflux, that we should at least do an ultrasound on that, on the new baby, just to take a quick look. An actual inheritance pattern has not really been very clearly delineated. So physiology of reflux, I think this is something that can be difficult for families to understand, but it can be quite beneficial if you take the time to explain it. And it really is a failure of the ureterovesicular junction, so sort of this area, to act as a one-way valve. And I think lots of families just assume there is a valve there to keep urine from going backward, but there's not. I always tell them that would have been a much better design, but we didn't get that, so we're stuck with this. And the risk of reflux is really related to the amount of ureter that is tunneled into the bladder. So you can see in this schema here, if you just have this amount of ureter that's actually through the bladder muscle, when the muscle contracts, only this much of your ureter is actually going to get compressed, and you're more likely have enough force in your bladder to reflux urine retrograde. If you actually have your ureter that doesn't come out until down here around 2, perhaps you'll have a little bit more compression of that ureter, and with bladder contraction and less likelihood for reflux. And then grade 3, at this third spot, you can see there's a lot of that ureter that's tunneled through that bladder wall. So there's a lot of muscle compressing on that ureter during voiding, and reflux is relatively unlikely. So a little bit about grading. I stole these from CHOP quite a while ago, but they're very nice, I think, and very easy to understand visually. So no reflux would be up here in the corner, and then just slow increase in the degree of reflux. You can see grade 1 is a little reflux into the very normal ureter, not even all the way up into the pelvis. Grade 2 would be into the pelvis, and then with 3, 4, and 5, you're starting to see perhaps a little bit of dilatation of the ureter, a little more filling of the calyces in grade 3, and then grade 4 and 5, you can see you have a dilated ureter, very dilated over here in grade 5, and in grade 5, really sort of blown out kidneys, so really sort of refluxing all the way into all of those peripheral calyces, and starting to sort of see blunting of those calyces because of the reflux. So another thing, a question that we get a lot from families, and I suspect you all do too, when you suggest VCUGs to families, they say, can't we just do it with an ultrasound? Why do we have to do this invasive VCUG? And there's lots of instances where high-grade reflux can actually be present in the absence of hydronephrosis. So really that's an insufficient study to evaluate for reflux. And just briefly, a review of what a voiding cystourethrogram is. There's a Scout KUB just to make sure that everything looks normal. Bladder catheterization filled with contrast, and then fluoroscopy, both before and after before and after the catheter is removed, ideally including voiding phases. And in little guys, the voiding phase is easy to get because when you pull the catheter out, it stimulates them to void, and you easily get a voiding phase. In potty-trained kids, they can be a bit more difficult because they don't want to pee on the table. They've been told that was the wrong thing to do. And so sometimes it takes some coaching to get them to be willing. But and sometimes in little guys, we don't get a voiding phase, and there's not much you can do about that. And it's usually just commented in the report that there was no voiding phase. But you can certainly have reflux that was not present with a full bladder and only present with voiding. So important to remember that. And I'll briefly throw in, our practice does not support doing sedated VCUGs exactly for that reason. I do think there are some other groups and some other radiology groups who are willing to do them. But our feeling really is that you need the voiding phase. And if you have a sedated kid, they're not going to void for you. So we don't do them sedated. So here's a nice picture for you. You can see right is on this and left is on this side. So you can see grade 5 on the right, and you can definitely see sort of this blunted calyces, very tortuous ureter, definitely impressive hydronephrosis. And then grade 2 here on the left, which is relatively mild, looks like a pretty reasonable looking ureter and just filling the collecting system a little bit right there. So the natural history of reflux is something that that I really try to impart on families because I think it can make them feel quite a bit better. And reflux usually resolves, or excuse me, often resolves over time. And the reason for that is as the bladder and the ureter grow, the intravesicular portion of the bladder, or of the ureter, excuse me, may grow, and you may get more of it that gets compressed, and you may just outgrow your reflux. This is a great table. It's quite old, from 1999, but I think it's incredibly helpful to get an idea. So here's grade 1 reflux. This is 5 years, when kids are 5 years old. This is the percentage of kids who will outgrow them. So you can see that by the time you're 5, about 85 to 90% of kids will have outgrown grade 1 reflux. Grade 2 is similarly good prognosis, with really about 70 to 80% of kids outgrowing that by the time they're 5. You can see not quite so good with grade 4. Here's unilateral and bilateral. They don't even have grade 5 on there because no one typically outgrows grade 5. But you can see that the likelihood of outgrowing higher grade reflux is significantly smaller. And those are families that we will refer to urology sooner because we don't think that there's much likelihood that they'll outgrow their reflux over time. So why do we care about reflux? I think is a valid question. And we certainly know that reflux places kiddos at risk for recurrent urinary tract infections. Anytime you have a bladder that is full of urine, whether that's from a dysfunctional voider, whether that's from a neurogenic bladder, or reflux in the case where you empty your bladder, but because such a high degree of urine went retrograde, once the bladder relaxes, all that urine is going to drain back down and sit in the bladder. So those kids don't ever have a completely empty bladder, and that increases their risks for urinary tract infections. And then kids who have urinary tract infections and reflux increase their risk for pyelonephritis and scarring because they're refluxing infected urine up into their kidney. And that was really well documented in the RIVER study. Again, I highly encourage you to look through that if you haven't, that the higher grade reflux certainly was correlated with an increased risk of pyelonephritis. They didn't see any significant correlation with scarring, but it wasn't a very long study period. So there's quite a bit of speculation that if those kids continued to be followed and DMSA scans were done on them further out, that we may actually see the scarring come to fruition, that those kids have more scarring. So again, morbidity of reflux, repeated urinary tract infections, repeated pyelonephritis can result in scarring. And significant scarring can lead to a decrease in renal function. And I just sort of threw this number out just to help, I think, remember why we care so much about reflux. And in the NAPRTICS, which is the North American Pediatric Renal Transplant, renal trials and cooperative studies, which is a big name for a bunch of centers who just pool their data to look at kids with chronic kidney disease, dialysis, and transplant. And in that, again, relatively old data, but at that point, in 2008, 5% of transplant patients had reflux nephropathy as their cause of end stage. So even if we could prevent some of those kids from going to end stage by identifying and repairing their reflux, that would certainly be significant, I think. So that's it for reflux, and we'll move on to talking about obstruction. So obstruction can occur obviously at lots of different places. I'm sure my urology colleagues don't love it, but I always talk to families about plumbing because I think it's something that they're sort of at least familiar with, and I kind of talk about kinking a garden hose, and depending on where you kink it, you get back up behind that, and that's really sort of what we're seeing in the urinary system. So you can have an obstruction here at the UP junction, so ureteropelvic junction. You can have a problem here at the ureterovesicular junction where the bladder meets the ureter. And you can have a problem here at the urethra where the urine's trying to exit the bladder. And all of those will result in backup from that point retrograde. So an abnormality here at the urethra is going to lead to a backup sort of everywhere, and versus an abnormality here, you're going to really end up just affecting that kidney and not that ureter or bladder. So that can sometimes be helpful for families to understand. And we'll start with UPJ. It's the most common cause of antenatal obstruction. About 1 in 500 of those who had a routine prenatal ultrasound had a UPJ obstruction. Male to female ratio, it's more common in males. All obstructions are more common in males. They're also all more common in the left. We don't exactly know why they're more common in the left, but it must have to do with just sort of developmental stages. And then about 10% are bilateral. And you can see here that with the obstruction, you usually have dilatation of the pelvis, but a relatively normal-looking ureter, and the bladder should be pretty normal as well. The etiology of UPJs can be multifold. You can just sort of have an intrinsic narrowing of the ureter right here. Usually it's that upper segment of the ureter. You can have a kink in the ureter. Sometimes you can see that if you have an ectopic or abnormally rotated kidney that kinks the ureter. You can have a compression, so a vein, some vessel somewhere perhaps is crossing over that and causing compression. Again, probably more common to see that in the ectopic or malrotated kidney. Frequently, the identification can be estimated, at least on ultrasound, although you'll need a LASIK screnogram for confirmation. And just for those of you who haven't seen a LASIK screnogram in a while, just sort of a reminder, you get two pictures. So one is just sort of the degraded uptake of the nuclear material and then watching it sort of drain into the bladder. And you can see here, the uptake is quite nice in both kidneys, but the uptake just sort of persists in this kidney here, and it doesn't ever drain as it starts to drain in the other kidney. And then this is what I actually find beneficial, is you can see a very nice uptake here in the left kidney in this sort of teal, and a very appropriate excretion. It usually will identify for you when the diuretic was given, when the Lasix was given. We do them with Lasix because frequently we'll have a partial obstruction that's overcome with a large volume of urine, and usually our urologists are pretty willing to watch those and don't necessarily need surgical intervention. And then you can see the right kidney, which is this pink guy here, which really doesn't do anything. Has some adequate uptake, but it doesn't really ever empty. And that gives you, sort of hits the nail on the head right there that you have either a UPJ or UVJ obstruction. The other nice thing that you'll get on a LASIK screnogram that I didn't include here is differential function. So it'll tell you how much each kidney is contributing to the whole. That can be helpful information when trying to decide about surgical repair. And then a ureterovesicular junction obstruction are a bit less common, second most common cause of prenatally detected obstruction, 1 in 10,000. Also male predominance in the left ureter more commonly than the right. Again, about 10% can be bilateral. You can see that the difference here is that you have a dilatation of your ureter. So that lets you know that the obstruction isn't up here somewhere at the UP junction, but it must be a little bit further down distally. Etiologies of ureterovesicular junction obstructions can be multifold. You can have a narrow distal ureter, so a problem sort of down here, even if you have a normal junction here. You can certainly have a stone blocking. You can have abnormal peristalsis, where the ureter is just not squeezing appropriately. A primary megaureter, where you just have a big abnormal ureter. All of those things can result in sort of a clinical finding of a ureterovesicular junction obstruction. Also frequently suspected on ultrasound, because you may actually have hydroureter in these kids. So if you see the ureter on ultrasound, you know that's pathologic and there's something going on there. And then again, confirmed with a Lasix renogram. And you can see again here on this Lasix renogram that this one here actually shows a little bit of contrast, a little bit of the nuclear material in the ureter. So that's a little bit more likely to be a UVJ than a UPJ, which you would not typically be able to see that ureter light up. And then post-urethral valves, the reports of incidence vary significantly between 1 in 5,000, 1 in 8,000 live births. Some report only up to 1 in every 25,000. I suspect it's a bit more common than that. And as you recall, it's retention of embryonal duct tissue in the prostatic urethra, so right down here. Most common cause of male lower urinary tract obstruction. And again, it's the lower urinary tract. So in theory, all of this was typically pretty normal, but because we have an outlet obstruction in the bladder, we have everything sort of backing up to varying degrees. And it does, the degree of which you sort of have reflux and hydronephrosis can vary significantly in kids with valves. But when you see this type of a picture, you really need to be thoughtful of the possibility of an outlet tract obstruction. This is a great picture of VCUG. So VCUG should be diagnostic for valves, because you put your catheter in. You may have trouble getting your catheter in, which may give you a bit of a sign. But once you get your catheter in and you fill up your bladder, you very well may see reflux, which is not documented on this picture. But when you take the catheter out and the infant voids, you'll see a very dilated proximal urethra and sometimes a very atretic distal urethra. So that's diagnostic of valves. And then briefly, a multicystic dysplastic, as I mentioned, we know it's not hydronephrosis, but frequently can be confused, and families may have been told it's one or the other. So important to keep in your differential, I think, when you're thinking about prenatal hydronephrosis. It's the most common cause of an abdominal mass in newborns, relatively common, 1 in 4,000. I feel like we probably see a good bit more of that. And it probably has to do with an irregular connection between those two different tissue sources that we talked about at the very beginning, just sort of not coming together properly. And it results basically just in a bunch of non-communicating cysts. There's very little, if any, normal renal parenchyma. It's a non-functioning kidney that doesn't really make any urine. It will have a ureter most of the time. Sometimes you can even have reflux into that ureter, but I think it's important for families to understand it's a non-functioning, sort of non-kidney entity that just doesn't work. And usually, another important thing to talk to families about is that it will involute. So the majority, at least 50%, will involute by the time kids are 5. We even see them involute later on in life. We will ultrasound these kids usually once a year. Important to know that associated anomalies can occur in about 50% of the kids, either on the side of the multicystic dysplastic or on the contralateral side. So frequently we will get a VCUG just to be certain that the contralateral side is healthy. Rare associations, hypertension and malignancy. I would say 20 to 30 years ago, there was a lot of concern about multicystic dysplastics and were they pre-malignant and did they need to be taken out? And in fact, most of them were taken out at that time. Now we take them out almost never, really only if they're causing a problem. Sometimes they will get so big as opposed to involuting that they cause sort of some mass effect, and that can be uncomfortable. But the malignant transformation is incredibly uncommon and does not really need to be a concern. And this I just sort of popped in here because I think it really brings to light how one might be confused as to whether or not you were seeing a multicystic dysplastic or a hydronephrosis. And you can see in this kidney up here, depending on the angle, you could very easily think these were just cystic structures. But when you really get in there and look, you can see that they're connected, which means that really it's just a severely dilated pelvis into these peripheral calyces. Versus this guy down here, really, we don't see, at least in this picture, any communication of these cysts. And that's really where your ultrasonographer and your radiologist can be very helpful in really taking the time to try to identify whether or not you think there's communication. Because if you think there's communication and you think this is severe hydronephrosis, you may want to get this kiddo to your urologist to talk about decompressing that system. Versus if it's a multicystic dysplastic, there's no urgency and nothing that really needs to be done for that kiddo. So briefly, we'll talk a little bit about management. And again, we talked about repeating that ultrasound after birth within 48 hours is ideal. And if there's hydronephrosis on the postnatal ultrasound, then we kind of go through our checklist. Is it severe enough that we need a VCUG? Is there a reason to check BUN and creatinine or electrolytes? Are we concerned about renal function? If there's reflux, are we going to prophylax or not? And then sort of thinking about whether or not kiddos can stay locally or if they need to be referred in to either see urology or nephrology. And certainly kids with reflux probably deserve a consult. You know, it says nephrology or urology, but now that we have 2 urologists, we're all for sending them there. Because they'll be the ultimate people to obviously take care of that if need be. If it's a multicystic dysplastic kidney, you know, do we need to get a VCUG to rule out any contralateral abnormalities? Do we need a renogram because we're not totally sure if it's a multicystic dysplastic or not? And sometimes we will do a renogram just to look for function because there really should be no function if it's an MCDK. And then obviously if there's an obstructive process, you need a urology consult. Discuss whether or not you need prophylactic antibiotics. Frequently they'll ask for Foley placement depending on what's going on. So that's definitely a call to the urologist for sure. And then back to our cases quickly. A 38-week AGA male with known uterolateral severe prenatal hydronephrosis. So some of the possible etiologies for this kid could certainly be reflux or an obstructive process. That would be pretty hard to delineate prenatally. So this is a kiddo who definitely needs an ultrasound and a VCUG. My suggestion would be that that's done before the baby leaves the hospital, because then you really can give the family the guidance that they need and get them referred to the proper place if need be. And any baby who has any significant abnormality, I would always advocate for checking a baseline serum creatinine, because then you're going to know sort of where you started from if at any point you get into trouble. Second case was a 28-week premature infant, now 4 weeks old, feeding and growing with a UTI, febrile UTI. Certainly reflux is going to be highest on our list for that kid. So that's a kid who we would recommend an ultrasound and a VCUG after treatment. So certainly we prefer that there's a test of cure for a urinary tract infection before we proceed with the VCUG. 10-day-old in your office for a routine newborn check and this finding of a cystic kidney. So as we just talked about, I think the question is this hydronephrosis or is it an MCDK? And certainly there's lots of other cystic diseases that we didn't talk about, which would be worth ruling out, obviously, in this new little person. So a renal ultrasound for sure needs to be done. And then I think consideration of a VCUG or a Lasix renogram really based on the findings of the ultrasound and how confident your radiologist is that you're seeing a multicystic dysplastic versus not. And then the last, parents in your office for a prenatal visit and severe oligohydramnios, bladder distension, a bladder stent placed at 22 weeks. Certainly this is a concern about a fetus that has a bladder outlet obstruction or a neurogenic bladder, some abnormality with emptying the bladder, so valves, neurogenic bladder, something of that sort. Management, obviously, this is a kiddo who probably will be best served to deliver at a center that has a urologist, if that's possible, because if there are valves, sometimes there's difficulty in getting a catheter in, sometimes those valves need to be ablated urgently, or the bladder, we need a suprapubic tube to get that bladder drained. So if that's a possibility, that's always a great option for those families. And then lastly, I included on here very small, so you'll have to blow it up. But this is sort of our little protocol. It's a bit old, but I think it really still is what we would encourage providers to do with infants in the nursery. And it just sort of goes through based on the degree of dilatation and what our recommended follow-up would be. And then things that definitely require referral and things that perhaps could be followed up by a primary care provider. You'll notice that if you compare these with the published recommendations from the Journal of Pediatric Urology, these are a bit more conservative. We talk a lot about using 7 to 10 millimeters as our cutoff, and I think, you know, that's probably born out of our patient population and our desire to make sure that we don't miss any kiddos who may not either have the greatest follow-up care because they have chosen not to do that, or may live remotely and it's difficult for them to get in. So I still think we're a bit more conservative than sort of that 10 to 15 millimeter that you would read about in the consensus paper. But again, I think you'll find very similar, you know, very mild hydronephrosis can just be repeated with an ultrasound in 1 to 2 months. More significant than that, you should probably proceed with some investigation to look for etiologies. And that's it. Happy to take any questions.
So if anybody's typing anything in, one is that a note to us is that we should probably put your protocol as an attachment in one handout to the Moodle session so people can see it. Right. So while we're waiting for people to answer, I have a couple questions for you.
Of course.
How common is it that someone gets an ultrasound during pregnancy?
Almost everybody.
Really? For renals?
No, just screening.
Just screening.
Yep,
and
so
it would be something that...
It's usually at 18 to 20 weeks.
And that they would actually be looking at the kidneys at that
point. They
point.
do look at the kidneys, and they usually will say 2 kidneys versus 1, and they will usually say normal bladder and plus or minus hydronephrosis.
The only reason I asked, my kids are older, so
right, exactly.
That was not a routine thing.
And that's one of the things I think it's important for families to understand is we see so much more of this than we did 20 or 30 years ago because every mom gets an ultrasound. Anyone who is getting prenatal care at that time will be referred for an ultrasound. And then presumably people who didn't present for prenatal care until later will probably be ultrasounded later just to be sure that everything is okay.
And you mentioned something about family history. So if a child, previous child had one of these things, then how early would they go looking for that?
So I would always recommend just a screening ultrasound after a baby's born within the first couple months of life. And if there's no hydronephrosis on the ultrasound, I would stop. And then obviously if that baby gets a urine infection, then you would proceed with the BCG. I would not do a BCG on every kiddo. That's a bit invasive, but I think a screening ultrasound is very reasonable to do.
Okay, cool.
Hi, this is Elaine Silos.
Hi.
Hi, thanks for your talk. I'm a neonatologist, and exactly for what the reasons you just mentioned, we have seen so many antenatal hydronephrosis diagnosed, and seems to me that we do many more VCUGs than are justified. So I have had a little interest in this area to try to at least avoid the VCUGs. So one question that I have is if antenatal hydronephrosis is resolved on the 3rd trimester, no more conservatively, some people still want to get a renal ultrasound. And I have recently proposed a guideline, which I'm still working on it, and I was proposing not to do a renal ultrasound when it was resolved in the 3rd trimester.
I would agree. I think if you have a prenatal ultrasound that demonstrates no hydronephrosis, I don't know that you need to do a postnatal ultrasound. What we find a lot is the most recent prenatal still had hydronephrosis and the initial postnatal did not. And I always recommend that those babies get a second ultrasound at about a month. Because if that first ultrasound is within 24 hours and the baby's dehydrated and not nursing well, frequently you won't see the hydronephrosis, and when you repeat at your 1 month, it will be back. So those are kids that I don't think should be missed, and we should definitely do one more on those babies. But I think if it's gone prenatally, I don't think you need to do a postnatal.
Okay, thank you. Yeah, and that's what I am proposing too on the mild hydronephrosis, just to repeat it 4 to 6 weeks, and then only do VCUGs on the moderates, which,
yeah, I think that's very valid. And I mean, I will definitely tell you that when I trained, I would have, and when I first got here, I would have said a VCG for everybody. But I've gotten a bit more lax, I think, over the last 10 years. And I agree, if it's a good family and you can be confident that they will be vigilant in looking for urine infections, I think that it's fine to forego the VCG in the mild.
Okay, and then for the premature babies who are born at, let's say, 30 weeks, and we know that there is a mild unilateral hydronephrosis. And I usually what I'm proposing is to delay that initial VCG for when they are around 32 weeks, if it's only mild, which seems my interpretation of that consensus paper that you mentioned. And, try not to do so soon in their course, because first we're not going to do anything about it unless it's something severe or even moderate, and then we diagnose what that is.
Yeah, absolutely. I agree with you. I think the ultrasound after birth is important, but typically in our NICU, we recommend they do the VCG before discharge. And that even gives you, in the kids who are really tiny, that even gives you a couple of months to see if their reflux if their hydronephrosis resolves, and you may spare them a VCG altogether. But in that scenario where they're obviously being closely monitored and you will pick up a urinary tract infection very easily, I don't think there's any problem with holding off on the VCG.
So how would you answer the more conservative approach, when people question you, okay, if you are in the patient population that we deal with, which ours is the same as yours, where I am at Presbyterian, mild hydronephrosis, or even like, an antenatal mild hydronephrosis, you do postnatal ultrasound, it's either still mild or resolved. And if I do not do a VCG, I'm going to miss them, and then they are going to end up in end-stage renal disease.
So that's I suspect that you're referring to Rob, and he actually told me I should make sure that I tell everybody what his protocol is as well. And I do think he may do a few more VCGs just based on what he said to me. And I don't know, some of it's practice style, and I think that's a little bit hard, I think, to pass judgment on, for sure. I think the more conservative thing is certainly to do them. I certainly think as nephrologists, we get incredibly nervous about missing the one kid who's going to come back in end stage. And because we all have that one kid. And if only we could have, identified that person when they were little and perhaps prevented this. But I think if you feel like you have a very reliable family and you have very mild hydronephrosis, I would certainly be of the camp to just continue to monitor with ultrasounds.
Okay, thank you.
You're welcome. Any other questions? All right, well, thank you very much. I appreciate the opportunity to talk with you.
Thanks so much.